All right, let's jump right in. Today we're talking about something absolutely critical in trauma care, antibiotic prophylaxis. This is a high-stakes world where every single decision we make is a calculated move against a microscopic enemy.
And this quote right here, it just nails the central challenge, doesn't it? See, in trauma, contamination isn't some if, it's a when. The second that tissue is exposed, it's contaminated. So the real race, the real battle, is stopping that inevitable contamination from blowing up into a full-blown clinical infection. We're basically jumping into this tiny, critical window of time to shut down the threat before it can even dig in.
Okay, so this is a really important point to get straight. Prophylaxis in trauma is a whole different ballgame than, say, in elective surgery. In the OR, you're trying to prevent contamination in a sterile field. But in trauma, the contamination has already happened. The injury itself was the contaminating event. So what we're doing is really more of a presumptive therapy. We're not preventing, we're acting on a known bacterial challenge, trying to wipe it out before it has a chance to become a real infection.
So where do we start? Well, let's build this from the ground up. We're going to start with the most common scenario you'll see, the open fracture. And we'll begin with this simple stuff, the lower risk cases, because that's how we can build a really solid, evidence-based foundation for everything else. So let's look at a case. Picture this, a 25-year-old soccer player, healthy guy, low energy injury. The bone poked through the skin from the inside, leaving just this tiny, pretty clean wound. This is your absolute textbook, classic Gustilo-Anderson type 1 fracture. It's about as straightforward as it gets in the world of open fractures.
And for a case like that, the protocol is, well, it's beautifully clear. This is where the evidence really shines. For these low-risk type I and II fractures, we go with a first-generation cephalosporin, like Cefazolin. Why? Because it's a sniper rifle. It perfectly targets the bugs we expect to see, the gram-positive stuff from the skin, staph and strep. And here's the kicker. We stop at 24 hours. That's it. This is antimicrobial stewardship in action, right? The narrowest possible spectrum for the shortest effective time.
Okay, pop quiz time. Let's throw a wrench in the works. Same type I fracture, but this time, your patient has a chart that screams anaphylaxis to penicillin. What's your go-to antibiotic now?
If you said Clindamycin, you're right on the money. Look, Cefazolin is a beta-lactam. And while the cross-reactivity with a mild penicillin allergy is super low, anaphylaxis is a hard stop. You just don't go there. Clindamycin gives us that excellent, targeted gram-positive coverage we need, making it the clear, evidence-based choice in this situation.
All right, we've covered the easy stuff. Now we get to the heart of the matter, the central conflict. We are now entering the territory of the big, nasty, high-energy, severely contaminated type 3 fractures. And this is where things get messy, where the evidence gets murky, and where the major guidelines actually start to disagree. This is a true clinical crossroads.
And this slide lays that conflict out perfectly. You've got two camps. In one corner, you have the traditional East guideline. It says for these bad fractures, you go big. Add gram-negative coverage and run the antibiotics for up to 72 hours. But in the other corner, you have the brand new 2022 SIS Guideline, and it throws a major counterpunch. It says, hold on, no routine gram-negative coverage, and we're stopping at 24 hours max. So you've got this classic battle, the traditional cover-everything approach versus a modern, very stewardship-focused philosophy. And that's why this quote is so powerful. This isn't just some minor update. The SIS Guideline is calling for a fundamental shift in our entire philosophy. It's forcing us to ask a tough question. How do we balance the risk to this one patient in front of us against the massive long-term risk of antibiotic resistance for all of society?
Okay, let's bring this debate down to the bedside. Here's your patient, a 45-year-old farmer. Mangled femur, the wound is just packed with dirt and soil. It's a textbook, maximal risk, Gustilo-Anderson type 3B. This is it. This is the case where you have to pick a side. Do you go with the old school 72-hour broad-spectrum blitz, or do you follow the new 24-hour stewardship-driven path?
So let's test our understanding of this new guideline, sticking strictly to the 2022 SIS recommendations. For this farmer with this horrible injury, assuming you don't see any signs of an active, raging infection, what's the absolute maximum time you're running those prophylactic antibiotics?
24 hours. That's the answer. And that right there is the single biggest takeaway from the new guideline. It looks at the old 72-hour rule that we've been following for decades and says, show me the evidence. The argument is that the data to support that long duration just doesn't hold up, and the principles of stewardship demand that we be better, that we be shorter.
Okay, let's zoom out a bit, because these principles, they're not just for broken bones.
To be really effective in trauma, you have to become something of a medical ecologist. You have to look at the environment, the mechanism of the injury, and use those clues to predict what kind of microbial bad guys you're up against, and then tailor your attack.
And this is what that looks like in the real world. A farm injury with soil contamination? You got to be thinking about Clostridium, so you add high-dose penicillin. An injury in saltwater? Now you're worried about Vibrio, so you reach for doxycycline. And what about freshwater? Well, that brings Aeromonas and Pseudomonas into play, so a fluoroquinolone is your best bet. See? It's smart, targeted prophylaxis. It's the absolute opposite of a one-size-fits-all strategy.
So far, all the bugs we've talked about have come from the outside world. But what about the risks we introduce ourselves? What about iatrogenic risk? A perfect example is placing a chest tube. It's a life-saving move, no doubt, but you've just created a direct superhighway for skin bacteria to march right into the normally sterile pleural space.
And when you look at the data for this, it's just, wow. It's striking. Without prophylaxis, the risk of developing an empyema, which is a nasty, devastating infection in the chest, is over 7%. But with just a single dose of antibiotics, that risk plummets to 1%. And this isn't from some small study. This is the powerful conclusion from meta-analysis that settled the debate and changed practice.
All right, final scenario. Let's make it real and high pressure. You've got a trauma patient crashing with a tension pneumothorax. They need a chest tube, like right now. But you don't have an IV yet. What do you do about prophylaxis?
The answer is simple, and it's all about putting the patient first. You put the chest tube in, period. You never, ever delay a life-saving intervention for a prophylactic drug. Then, as soon as you get that IV access, you give that single dose of Cefazolin. The principle is crystal clear. Save the life first, then give the antibiotic as soon as you possibly can.
Okay, so let's tie all this together. What's the modern mandate here? It's not about just memorizing a bunch of protocols. It's about a deeper understanding. It's about internalizing the core principles of evidence-based medicine and antimicrobial stewardship, and then using your brain, using sophisticated clinical judgment right there at the bedside.
So here are the big takeaways, the rules to live by. First, move from rigid protocols to flexible principles. Second, always use the narrowest effective antibiotic spectrum for the shortest proven duration. Third, never forget that the surgeon's scalpel, good debridement, is the absolute cornerstone of preventing infection. The antibiotics are just helping out. And finally, you have to embrace antimicrobial stewardship. Don't see it as some annoying restriction. See it for what it is, a crucial part of providing excellent care to your patient.
And really, that's the ultimate goal, isn't it? In trauma, the scalpel and the antibiotic are two of our most powerful tools. They're inseparable. But true mastery, that's not just about knowing how to use them. It's about knowing precisely when, why, and maybe most importantly, for how long. All guided by the best evidence so we can get the best outcome for the patient in front of us today while making sure we can still treat the patients of tomorrow.